on to what is sure to be the most exciting part of our AGM, which is our panel discussion. And we are just so thrilled to have Rebecca and Andrew join us. And the panel is going to focus on the impacts of UCP privatization schemes on our public healthcare system. And I'm just going to introduce our guests briefly. We have Rebecca Graff McRae, a research manager for Parkland Institute. She completed her undergraduate and doctoral studies at Queen's University in Belfast, exploring the role of memory and commemoration in post-conflict transition. She has previously worked with the Equity Commission for Northern Ireland and Edmonton City Council, and she's held a postdoctoral research fellowship at the Memorial University in Newfoundland and the University of Alberta. Her work with Parkland Institute often focuses on healthcare, privatization, and short staffing, and the impact of Alberta's healthcare and senior care system. So thank you, Rebecca, for joining us. And we also have Andrew Longhurst, who is a health policy researcher, political economist, and PhD candidate in the Department of Geography at Simon Fraser University. He's a research associate with the BC Office and Canadian Centre for Policy Alternative, and has published numerous reports, including Reducing Surgical Wait Times, The Case for Public Innovation and Provincial Leadership, which was co-authored by Marcy Cohen and Margaret McGregor in 2016, and The Concerning Rise of Corporate Medicine in 2022. He's a frequent commenter on public health policy and issues in regional and national media. So we're very excited to have both of you joining us. And I don't want to stand in the way of any wonderful information that you're going to share with us today. So I'll let you take it away, please.
We didn't discuss prior as who was going to start, and we were waiting for Karen to flip a coin. So I think there was a little game of chicken happening here, like who's going to unmute first.
Sure. I was having some technical issues signing on, so I didn't have a chance to flip a coin. But how about you start us off, Rebecca?
There we go. I lost because I can't stand an awkward silence. Yeah, so it's nice to be here. Thanks so much to Friends of Medicare for inviting me to join you this Saturday. There's a lot, unfortunately, entering the first days of this new UCP term in government. There is a lot that we could talk about around healthcare privatization, and that, frankly, is a pretty depressing statement to have to make. But I think one thing that I want to be able to highlight today is the voice of workers who are in some of these battlegrounds across our public health care and who are already experiencing some of this privatization, and to talk a little bit about what those impacts are from their perspective and how we can start to support them as well. So a year ago, in January 2022, I authored a report for Parkland Institute on the privatization of the further privatization of lab services here in Alberta. And some of you will no doubt be aware that there's a very long roller coaster sort of history with lab services in this province, going back decades. It's a private service, it's a public service, parts of it are privatized, parts of it are put under the public realm again, even going back just as far as the 2014-2015 scheme to bring in the Australian corporation Sonic to take over the northern zone services for Edmonton and northern Alberta, which I know many Friends of Medicare members had a very active part in highlighting some of the I guess the risks and the concerning impacts of that particular proposal. So since then, that's 8 years ago. And in those 8 years, that roller coaster ride for labs has continued unabated. As you know, the newly elected NDP government canceled that Sonic contract. It was found that the request for contracts was improperly handled as it was designed by the then PC government. And the Health Quality Council of Alberta conducted a study into how best to reconsider laboratory services in Alberta moving forward. So that report, which you can find on the HQCA website as well, set out an entire plan for a integrated, coordinated, province-wide, wholly public lab system, which is what the NDP government then made these steps towards implementing. First, with the creation of APL, Alberta Public Labs, which was then part of AHS. So this was the plan that was in motion up until the 2019 election and the election of the UCP government. So from there, the pieces of that plan have been systematically dismantled. The hub lab that was already under construction in Edmonton, the autonomy of APL, even its name was changed from Alberta Public Labs to Alberta Precision Labs, I think because calling it Alberta Private Labs was just a bit too on the nose. So all of these pieces set a context for why lab in particular is a very sort of urgent canary in the coal mine on privatization here in Alberta, because they've literally been pulled in a tug of war between public and private ownership of public and private delivery over the last several decades. So there's a huge amount of instability and anxiety amongst the lab sector, and particularly how that affects lab workers already. So where we are now, following on from our report was released just ahead of DynaLife being awarded the new contract for province-wide community lab service delivery. So that's anything essentially outpatient. If you're not admitted to a hospital ward, then your lab testing will take place through DynaLife, and an awful lot of the processing of other more specialized testing is being taken over by them as well. So in the meantime, you may have seen a lot of the headlines that have come out over the last 6 or 8 months. The first one being that this takeover from Alberta Public Labs, Alberta Precision Labs, had to be delayed a number of times because there was simply not the staff capacity in the midst of a pandemic, in the midst of huge staffing crunches across the healthcare system, to enact what's really a logistically difficult changeover amongst staff. And so that process only took place in December of last year. And in the 6 months following, what we have seen is essentially what I flagged in a recent piece for Parkland, the I told you so's, where that service delivery is not living up to the claims that were made in order to justify that privatization. So I'm going to run through a little bit about some of those claims that were set out at the beginning. And of course, I'll try to be brief so that we've got lots of time for questions on that as well. So obviously, the first one that comes up when any government wants to justify privatizing a service is cost savings. We're going to save so much money off of this because the private sector is always cheaper than paying those greedy public workers. So I'm sure we've heard some version of that in a lot of sectors in healthcare. So this is unfortunately a really easy one to bust, because even the pieces of the government between the consultants that were hired by the UCP to find these cost savings, consultancy firm Ernst & Young, and AHS themselves can't agree on that number. How much was this contracting out to DynaLife actually going to save the province? So the initial estimates from Ernst & Young were hundreds of millions, 100 million and upward annually could be saved by privatizing these lab services. When AHS did their own analysis of those numbers, they had to revise that figure downward to between 18 and possibly 36 million, There's a huge difference. And there's really no justification for where Ernst & Young was getting those monumental figures. Other aspects of that cost savings myth is even something as mind-boggling as dismantling a lab center, the hub lab, that was already under construction. Now, the full cost of canceling that contract and demolishing the building, remediating the site, hasn't ever been released by the UCP government. But some of the documents on that show that simply the site remediation was upwards of 12 million. So there's no cost savings in taking a building already underway and turning it back to rubble and grass. And in the meantime, as we saw during the pandemic, that lost capacity for processing tests in the Edmonton zone and across the province could have had huge implications for COVID testing and keeping the routine testing for the health services running during those unprecedented pressures. And meanwhile, the final thing that we know about cost savings, if there are any, they don't come from the company offering those services. They have to provide a profit margin to their shareholders. In the case of DynaLife, those are two very large corporate entities. One's an American firm called LabCorp, and the other is owned by the Ontario Public Service Union pension fund. So those people want their return, and any savings that are made come off the backs of lab workers themselves. What we've seen in the meantime, despite promises in the contract that any workers being transitioned from APL to DynaLife would be kept under similar collective agreements and similar terms, there was up to a 7% differential in wages for employees who were doing the exact same job with the same experience and qualifications. So any of you following the news today, there has only just been an agreement reached tentatively to put to DynaLife employees on that today. So the cost savings myth is smoke and mirrors. This isn't saving Alberta any money, and it's actually costing lab workers in their income, their quality of work as well. The system's not more efficient. It actually perpetuates fragmentation within the system. Now we've got, certain tests that have to happen within hospitals, some that have to happen through DynaLife. There's a system called stat testing, which has to do with tests that are urgent or have to take place within a certain time frame, and they have to be processed in a certain way. Often, the most efficient way to get those done was to send patients to their hospital outpatient lab. And now that's not possible. They're supposed to go and do a walk-in at a DynaLife site. But now the DynaLife sites, as we've seen, are understaffed, oversubscribed. They have long wait times. You can't get an appointment. And what they're asking patients to do with these stat tests is to come in, check in at the DynaLife site, and then they will send them back to their hospital outpatient lab where they can wait again, because DynaLife simply hasn't got the capacity to process those in the time necessary. So all of these claims about efficiency is simply a duplication of systems that are now not even connecting up the way that they're intended to. And in the meantime, that has huge impacts for the quality of service that is being offered to patients. As you said, these wait times, it's not just inconvenient for patients, that actually has very serious implications for processing those tests on time, for getting the results back to healthcare providers and therefore patients to make a timely diagnosis. And it reduces that access for patients as well, when suddenly the only center for them to get their testing done is completely oversubscribed. What we're seeing even 6 months later, particularly for patients in the Calgary area, is they're trying to book appointments, hundreds of kilometers away, going well outside that Calgary donut to smaller communities because they can't hope to get an appointment on time. So that question of access is a really important one, is not everyone has the ability to do that. And in the meantime, that has implications for quality of testing as well, where now with DynaLife taking over some of this processing, they're making medical decisions around what tests they will do. I've heard from lab workers at the University of Alberta Hospital who are saying they used to run a series of preparations for certain types of tests that are essential for organ transplant recipients. They used to run 5 preparations because they all have a very distinct function. DynaLife says, no, unfortunately, we can only process 2 of those. So you just can't run those other 3. So suddenly that has implications for catching really rare but very life-threatening conditions amongst some very vulnerable patients. So overall, the big picture takeaway from this is that lab workers are suffering, they're being paid less, they're being put through huge amounts of uncertainty and precarity in their jobs, they're put under a lot of pressure, they're understaffed and overworked, they're taking the burden off of the system. And in the meantime, they're in a wider system of staffing crunches as well. There's no plan for attracting and retaining lab staff in the long term. And in fact, the instability in that and all of these pressures are making very experienced lab workers hesitant to stay in Alberta or to come to Alberta. So that question of the sustainability of this system over the long term is really in doubt. So in the meantime, I'll leave that positive note for all of you, and to think about labs in this instance as really the guinea pigs who are enduring the worst of both worlds with that privatization right now. Thanks.
Thank you, Rebecca. I think I'll just make an executive decision that we'll wait till questions until we've had both presenters present. Is that okay with both of you? And then, so if you have questions, just please keep them in your mind or put them in the chat, and we'll carry on with Andy. So you're next.
Great, thanks, Karen, and nice to be with everyone today. And thanks again to Friends of Medicare for the invitation. So I will provide an overview. I imagine folks are quite familiar with the Alberta Surgical Initiative and the report that the Parkland Institute published last month that I wrote, but I'll just provide a quick overview and I think just some thoughts around kind of where we're at now post-election and what we're likely to see and why that's significant. So as many of you will know, in 2019, the Alberta Surgical Initiative was announced by the Alberta government. And it was really focused around a pretty explicit expansion of for-profit surgical and diagnostic delivery of services. So they were largely drawing on the experience in Saskatchewan, which was and continues really to be held up as sort of the poster child of how privatization of surgical services is successful and how it reduces wait times and how it reduces costs. And so going into in terms of approaching this research project and having the opportunity to do that for the Parkland Institute was, I think, an opportunity to evaluate the Alberta Surgical Initiative on its own terms, in terms of the claims that had been made by government that it was the way to reduce wait times, it was the way to perform surgeries more cheaply, and it was the way ultimately to transform the system to be something that better serves Albertans. And so in terms of approaching that project, it was heavily reliant on freedom of information requests. and analyzing the publicly available data that we do have, largely through the National Canadian Institute for Health Information. And so what I did find, and it wasn't entirely unexpected, but it was quite a shocking finding, was that despite much of the rhetoric around the Alberta Surgical Initiative increasing capacity and its ability to help the province deliver more surgeries, what we saw in fact is an overall decline in the total surgical volumes in the province over the first 3 years of the Alberta Surgical Initiative. And I should say, and to be fair, this also, it's a challenging analysis because it coincides with the pandemic. And there's no question that the pandemic has been probably the most challenging event that has plagued health systems across the country. So taking that into account, but even still, what we saw when looking at the data is that we saw surgical volumes increase by 40% in the for-profit chartered surgical facilities. And at the same time, we saw a decline in surgeries performed in public hospitals by 12%. So this was concerning because as we know, most surgeries in the province are delivered in public hospitals. That's where the bulk of them still are performed, and where many people, especially for those that need more complex surgeries that aren't performed in these private for-profit facilities, that's where they ultimately will have their surgery completed. So looking at that, it was quite a shock. And so just back to the pandemic piece, and this is where in the release of the report, there's been always some interesting response and commentary, even from government, that, well, you know, I wasn't accounting for the pandemic and this massive disruption to the health system. But what I did find, and what this report shows, is that the pandemic alone can't explain the fact that during the first 3 years of the Alberta Surgical Initiative, the overall provincial surgical volumes declined. And so when we look at the spending for public hospital operating rooms, we actually saw an absolute decline in funding to public AHS operating rooms over the life of the Alberta Surgical Initiative. So that was a real indication that the focus has been on expanding that for-profit delivery system in the chartered surgical facilities at the expense of resourcing public hospitals appropriately. The other way that we can understand what was going on, and that it was not just the pandemic alone, is that we saw staffing levels in staffed hospital medical and surgical beds. So these are for recovery, post-op recovery. We saw the funding for those decline, and we saw that the staffing levels for those decline. So we actually saw an absolute reduction in staffed medical and surgical hospital beds over the life, the first 3 years of data for the Alberta Surgical Initiative. So at the same time, we're seeing an expansion and increased funding flowing to the chartered surgical facilities, and yet we're seeing a decline in surgical activity in our public facilities. So I think it tells a pretty compelling story about a situation where government is explicitly choosing to favor a private for-profit sector and providing the resources for that sector at the expense of our public facilities. So it was, I have said this to a few people, and Rebecca, have been very grateful to work with Rebecca because she was ushering this project along at the Parkland Institute. But I think I said to her when I got the Freedom of Information request for the data, I said, it's rarely that this sort of analysis is so clear cut in the fact that the data is so striking, that it told such a compelling story about the shifting of resources from the public sector to the private for-profit sector. And I think that's really what we're seeing with the Alberta Surgical Initiative. And I don't think government has tried to hide that. I think they've been quite open about the fact that the priority here is building a market for for-profit surgical delivery. And that's in essence what they're doing with the Alberta Surgical Initiative. So, and then just in terms of the outcomes, and so the effectiveness of the Alberta Surgical Initiative, we know that the most recent data from 2022 from the Canadian Institute for Health Information shows that wait times continue to be among the worst in the country, especially for hips and knees, where Alberta is really only in competition for last place with Saskatchewan, a province that has focused tremendously on private for-profit delivery of surgeries and also diagnostic imaging. So the story is becoming, I think, increasingly clear, and I think the Alberta story is really important. As we know now, Ontario is moving in this direction. And Ontario will represent a very significant market in terms of these for-profit players, these corporations and investors showing interest in moving into for-profit surgical and diagnostic delivery. And so while we've had in BC, we have had a history and still, in my view, quite unhealthy reliance on for-profit surgical and diagnostic imaging in the province. Now that Ontario is moving in this direction, and now that Alberta continues to pursue this, and I think certainly with the re-election of the UCP, it's pretty clear that this direction is not going to change. I think it's concerning because now we're starting to see very likely greater interest from large-scale investors in delivering surgeries, and I think more broadly understanding this as a form of hospital privatization. So we're moving away from just what might be considered outpatient clinics to what Alberta has called chartered surgical facilities, what have been called independent health facilities in Ontario. But I think we're at quite a concerning and key juncture just in terms of our health systems, where we will start to see what look more and more like hospitals. Of course, they're not going to be performing emergency care or the more unpredictable, costly, and not profitable type of healthcare, but they will be interested in cream skimming the easy, simpler procedures and orthopedics and other forms of day surgery are why they're interested in providing those services, because it is the less complex and the more profitable type of healthcare delivery. So I think I'll conclude there, because I think there's probably I want to leave time for questions and probably more that we can touch on, but I just wanted to provide that overview. And I think moving forward, it is really important to be able to continue to evaluate whether the rhetoric matches the outcomes. And so I think this is an example, quite a stark example of how talk can be very cheap for politicians and for political parties. And yet it is really quite disingenuous when you evaluate the success or failure of these initiatives on their own terms. So you're saying it's going to reduce wait times. You as a government are saying that this is going to increase provincial surgical capacity, and we're actually seeing the exact opposite. So I think moving forward, we obviously will need to continue to keep a watchful eye on the Alberta Surgical Initiative. And as other provinces like Ontario move in this direction, and I know Manitoba, Saskatchewan, now Nova Scotia as well, Quebec is undergoing major healthcare reform with, I think we'll see greater movement in this direction. I think understanding what's at stake here, and I think what's at stake for our public hospitals and our workforce. And so this is, I think the thing I'll leave you with is, as we see greater movement of public dollars into for-profit facilities, we are going to continue to see that drain on our public hospitals and our public sector staffing. And in turn, that's going to make shortages and workload worse as those resources move out. And this is not a new finding. This has been documented for decades in health services research about the experience when you both expand private financing or two-tier healthcare, but also with a private for-profit delivery system where you're using public dollars, but you're using it to prop up and to create a larger market for for-profit delivery of care. And then I said I'd end there, but I'll I'll tack on one more takeaway is we already see that a number of these clinics are engaging in unlawful extra billing. So this is charging patient fees for services that are insured by the provincial health plan. My report did uncover that the Calgary-based Surgical Centers Incorporated, this was a regional chain that had clinics, surgical centers in BC and in Alberta. During the time that it held outsourcing contracts with AHS and with BC health authorities, it was audited by the BC government and found to have engaged in unlawful extra billing, contrary to provincial statute and at odds with the Canada Health Act. So we do, and I've done previous work in BC where we've seen 2 other facilities, and on the record, they were audited and engaged in extra billing. So we have a fact pattern. We know that this is a tendency in this industry. And so we need to understand these facilities as not just taking public dollars to perform surgeries and other publicly funded services, but also as a business model, they're looking to diversify and maximize how they make money and how they pass on their profits and returns to their investors. And the way that they have typically tended to do this is by either trying to skirt the law and sometimes through things like upselling, which may not be unlawful in and of itself. I think it's a really problematic practice, but we then also see explicit acts of unlawful activity like extra billing in this sector. So I think we need to both understand that they are a gateway to 2-tier healthcare, as much as governments that choose to go this direction say, well, this is all publicly insured, this is all to the letter of the law. The evidence speaks to the contrary. And so I think we need to continue to raise that and not allow them to convince us and the public that it's innocuous and it's publicly funded, so it's just public health care. Because these corporations, just like we've seen in BC with the longstanding Canby Surgeries Corporation led by Brian Day, they have spent a lot of time and resources striking at the legal foundation of Medicare in this country, and Canby spent over 14 years trying to dismantle the legal foundation for Medicare in BC, which would have ramifications across the country. So now I'll stop there and look forward to your questions. And again, thanks so much for joining us on your Saturday.
Wow, that's a lot of information from both Rebecca and Andy. Thank you so much. I could listen to both of you talk for quite some more time, but what came to my mind is I think you might have struck on a campaign slogan there, Andy. Talk is cheap, private healthcare isn't. But I just want to remind folks that there is in the documents, we have both of the reports of our guest speakers in there. So if you want to have a look at those and copy the link, please do so. And I'll start with some of the questions that are in the chat. Let me see the first one here. Barbara asks, how can members of Friends of Medicare coordinate in order to increase the likelihood that its voice is heard? And does Friends of Medicare work with other groups to coordinate the way it shares its concerns? So I think one maybe is for our panel guests, the first part of the question, and then maybe Chris could answer the second part. So how about you take a crack at the question first, Andy?
Sorry, as my toddler has a big tantrum next door.
That's okay. You want me to start with Rebecca?
I'm happy. So remind me, the question is how do we take action?
Well, how do we increase the likelihood that our concerns are heard?
Well, I mean, maybe to state the obvious, I think it's been building power through organizations like Friends of Medicare. In BC, we have our BC Health Coalition. And I think it's not without its challenges. There are tremendous challenges in terms of what we're up against, but I think the power through our health coalitions across the country have been. There's no question that we have been holding the line. We don't win all the time, but I think continuing to build out the membership and the organizations that are part of these coalitions is really important. And I also think extending invitations to organizations that are not traditionally active in the healthcare arena, in terms of being organizational members of Friends of Medicare or other provincial health coalitions, I think is really key. And I think we speak louder with that voice. And I think there's a lot of people who don't necessarily know everything that's going on in healthcare, but they know that it will impact them. So those are my 2 cents for what it's worth. But I really do think we need to continue building the power of our health coalitions, and I think extend beyond the usual suspects. So what are organizations that in the environmental movement, these are organizations that probably share similar principles and values, but we often work quite siloed sometimes. So I think continuing to think about how we build power through that.
Thanks. I'll let Rebecca have a chance to answer that question as well.
I don't think I can add too much to that because Andy's got a lot more experience with that part of organizing and mobilizing in a national way as well, right? I think that something to really emphasize is that across the country, there's people in BC and Ontario, absolutely, and some of these other provinces where these sort of trial balloons on private health services are being floated, where they're actively looking to Alberta now for some kind of like, wow, like look what's happening here. Look at the evidence that is coming out about their experience. And so I really think joining forces, because one thing we know is that volume, mass is the thing that starts to get government attention. And that was what started to punch holes in Klein's agenda. That's the only thing that is pushed back on the current or previous iterations of the UCP and the PCs is mass movement, mass discontent with what's happening, and saying we're not going to stand here and let it happen. So being able to join forces with groups across the country who are experiencing the same thing is really crucial.
Thanks, Rebecca. And then I'll just ask Chris to talk about other groups that we might be coordinating with and the way we share our concerns.
Yeah, I think I won't say a lot right now. I'll have my report, which will highlight some of who we're working with and what we're doing, and a chance for all of us to talk about what's ahead. But I'm just thinking we have these 2 experts on lab and surgery privatization and those impacts we're seeing. And if people have questions, I saw Robert and other that are specific to their expertise while they're here. Maybe we do that right now, and I can deal with some of those questions at our time.
Sure. Okay, well, let me look down the other list of questions. I think that's appropriate. I'll start with this question. What implications for the ability of enforcement of the Canada Health Act to address the dedication to public monies to build private systems? So, and along that same line, I'll say, has the ruling on the Dr. Day case helped our case, or has it had any impact in our concerns in Alberta? So this time, Rebecca, you go ahead, please.
Well, I think the first part for lab, they're sort of the exemplar here of something that was never specifically given mention within the Canada Health Act. It was considered that it was an integrated part of hospital services and not really its own sector. It didn't need its own mention. And that's something we've also seen with other diagnostic services, imaging, and X-ray and stuff as well, right? So if it doesn't get a specific mention in the CHA, there's a loophole for it. And what we're seeing, and I know Andy can speak to this so much as well, is wherever there is the possibility for a loophole, there are people who can make profit off of it. And so the difficulty, I think, for people is on the one hand, there are these egregious and very sort of blatant attempts to violate what is stipulated in the Canada Health Act, for example, with the extra billing. But what's actually more insidious is finding the gaps within that. That's something that we saw with these sort of private healthcare clinics or virtual health apps that charge for some of these things as well. So lab is one example where they very much feel like they're sort of left in the wind because they're an easy sector to carve out from the rest of the health service. But actually the work that they do is intimately entwined with hospital care and primary care in terms of being able to provide those diagnoses, right? So I do think that's something where the flaw is with the original legislation, that it can't anticipate what's going to be essential aspects of our healthcare as that technology and circumstances change. And there's a real difficulty for campaigners because there's a fear of, if we open up the CHA to make those updates, it leaves a vulnerability to some of those loopholes becoming permanent. So that's one space where it's a real gray area. But on the other hand, I think with surgeries, the black and white is sometimes a little clearer.
Right. Yes, thank you, Rebecca. I would agree with everything that you just said. And I'm going to try to actually get to as many questions as we can. We have about 5 more minutes for questions, and then we've made a commitment to let our guests be released to enjoy the nice day. Let me just see. It says, can we take yeah, I think the answer to this is no, but can we take Danielle Smith at her word when it comes to healthcare promises and what needs to be done to increase the number of healthcare staff to adequately handle the tremendous workload? So maybe Andy, do you want to try that question?
Okay, question 1, no. Next question.
Yeah.
I think, yeah, just to the issue of surgeries and the workload in hospitals and how, I mean, this is the issue, and it's similar to lab, it's similar to all healthcare services. The easy, more profitable services are the ones that the private for-profit sector is always going to want, and that's where they're largely already in business. And so as chartered surgical facilities expand, they will take on the easier cases, and the more complex work and the heavier workloads will be left to the hospitals. And so that workforce, of course, is going to be feeling the strain and the additional burden as the case mix continues to change in the health system, as more easy stuff gets sent out to the for-profits and the more complex workload is done in hospitals. So I think to answer that, I would say, well, we need to stop privatizing these services. So you're not destabilizing hospitals and the workforce by this distorted case mix where the complex cases are all landing in hospital and burning people out because the workload is increasing. And this is something that has been recognized in a number of other jurisdictions like England, where they have a for-profit surgical sector that's quite well established. And again, this is the effect that it's had there. Not unlike what we're seeing here is you destabilize your public hospitals because your cases are all the easier stuff gets sent to the for-profits. So I think that's a clear place to start. If we stop privatizing, you're not going to drive people out of the public sector, and hollowing out our public sector is really what's happening across the country. So as more and more people face that increased workload, they're going to be looking to work in a private facility. And I don't blame healthcare workers who are making those difficult decisions. I think any reasonable person, if they were trying to find a way to manage when you're facing moral distress on a daily basis, you're going to probably try to find a place to work where your hours are more regular and the workload is more balanced. I think that's a pretty reasonable response. So I think, the more that we privatize, the more that we are going to destabilize our public sector workforce.
Yeah, and I would add that I think that, workers themselves are at risk of being compensated less fairly in those situations as well. So I'm going to ask 2 more questions. I know that there's probably a long answer for both of these, but if we could keep it brief. Is there evidence that, or do we have experience of healthcare worker unions going on strike going on strike for strong anti-privatization language to be part of the solution? So I'll let one of you answer that, and I'm going to just look down here. So maybe Rebecca, do you want to comment on that?
I'm not sure about an example. I would look to that intrigues me though, is to say now who's doing this, who's winning that particular battle, because I do think that is a really important aspect of it. Firstly is about, yes, the language that gets built into the collective agreements. Oh, Peggy's got one in the chat there, and Trevor. So there we go. BCGEU, and Peggy had an example. Sorry, it's coming up while I'm going. See, you guys, you've got to share this knowledge so that we all have. Exactly, right? The difficulty, like from the lab's perspective, is they tried to anticipate some of these things, like I said, with the ensuring the language was around similar collective agreements and similar terms, but that was actually used in a really slippery way by Dynalife to change, for example, like job descriptions or job titles, or to have more casual or part-time staff rather than full-time positions, so they're in on different terms, and then to kind of leave that gap between people who were coming in and people who had been there originally. So that example, now I'm just looking at the HSAA agreement this morning, and if it's voted on by their members, might provide some keys to that language without a strike. But I think at the end of the day, what we all have to be aware of in the healthcare sector is withholding labor in an essential service might be the only way to really mean business with a government as determined as this one. And yes, the examples that everyone's putting up in the chat, let's do some research on those.
Yeah, and I'd add just briefly, the Hospital Employees Union in BC, there's a long history of HU over the course of the 90s, really building and strengthening their no contracting out language through collective bargaining, and that was then directly and explicitly targeted by the BC Liberals in the early 2000s, and when they ripped up contracts. And so that language has it's back, but it has been it was targeted because it was effective. And so I do think collective bargaining is absolutely and through labor action is really an important avenue to take this stuff on.
And the last question, the last word is, I just lost the question, but oh yes. Is there any help available at the federal level? Probably, I'll let both of you have the final word on that, and then we'll finish up this session.
I think the federal piece is really important. I think we have seen some good work by the federal government, but I do think they do need to take stronger leadership around issues around the Canada Health Act enforcement, and I think around questions of delivery. There's a lot of debate among legal scholars about to what extent the feds can be more interventionist or engaged in healthcare delivery, as opposed to just how it's funded and financed. But I think we do really need to see the federal government continue to assert itself. Otherwise, we are going to end up with even a more patchwork of healthcare systems that look very different in each province, and we will have no national standards or consistency for what healthcare looks like.
Rebecca, last word is for you.
I think that's about where I would come down on it as well. We haven't in something like lab, there's very little recourse to a federal sort of like rescue line because it's not covered under the Canada Health Act outside of that piece of in hospital lab testing, which is already sort of being carved off under that. So that's difficult. There's it's sort of like there's no rescue coming in that sense. But I think in the sense that Andy's alluded to, particularly with the new federal provincial health deals that were negotiated several months ago, is putting in very strong language about how that money can be used. That, you know, we're not sending you billions of dollars in checks in order for you to start privatizing out these services. There is potential there for the federal government to do that. They haven't done it to the extent that I'd like to see yet. On seniors care as well would be the other avenue that we really need to fight for that.
Yes.
Yeah, and I just to very quickly add, I think we really need to be talking about the fact that healthcare and social services, all type of human services, need to be delivered on a not-for-profit basis, whether that's publicly in many cases or nonprofits and seniors care, for example. But we have so much evidence of the problems with that. So I think that's an area where the federal government provides tremendous funding in the form of transfer payments, and we need them to use that funding power to ensure that we don't end up with a fully privatized system.
Well, I just want to thank both of you very much for your time today. Like I said, I'm sure there's lots more that could be said about the issue, but we really appreciate your expertise and joining us in the fight, because it is a fight. It's not an over exaggeration, and it's a fight worth having to protect our publicly funded and publicly delivered services. So thank you very much, and we appreciate your time. If you want to stay, you're welcome to, but if you don't want to, we understand. We understand that you might want to have a weekend off.
Take care, everyone.
Thanks so much, everyone. Thanks.